So we'll move on to our mock tumor board. I hope most of you patients have been seen by a tumor board, which is a multidisciplinary, if you want to start coming out, all of our presenters, a multidisciplinary team that looks at your case from all their different specialties to come up with what they consider to be the best treatment plan. It's really instructive to see how this works and see why we keep saying, go to a sarcoma center and be evaluated by a multidisciplinary team, because it's just so important, and so many people don't take this approach. So we have all the doctors listed on your program, except for Dr. Aaron Weiss had a family emergency and could not make it today. So I'll turn it over to Palma Dileo, who's going to manage the team.
Yeah. Thank you, Jeannie. It's really a pleasure to be back here in person. And as Eldad said before, this is really, really important. The multidisciplinary approach is incredibly helpful, not only when a patient has been first diagnosed, but also during the patient journey. So it is really critical to be able to give the opinion of multiple specialty. And today we have, obviously, you've seen some of the faces, apart from Dr. Ravin, that is a medical oncologist like me. And we have an interventional radiologist, a medical oncologist, and a surgical oncologist. And what we are trying to do here is somehow reproduce what, generally speaking, happens. And some of you will recognize their history, their story. And we start now. Okay, let's see whether this is working. So I'm going to present the story, general, very few information. And this is a 28-year-old man that was first diagnosed in August 2017 with a desmoid tumor of the right neck, had a biopsy, and we also did molecular translocation and see whether he had a T41A substitution. Went on and have a period of observation, but in September 2019, the MRI showed that there was an increase in volume over the last year, and he was mildly symptomatic. And so I'm going to also show some of his history in terms of the past medical history. He had previously, when he was very young, testicular cancer and other problems, epilepsy, and his family history. The grandfather suffered of bowel cancer at age of 80. And I'm going to show some of the, Okay. Any question from the panel?
Was he assessed with MRIs between diagnosis and progression, so did he have time for the smoke?
Absolutely. So he was on a regular surveillance program, and there was, generally speaking, for that location, particularly at the beginning of from the time of diagnosis, it was a closer surveillance, and it was stable. And only in the last, I'm going to go back here. Only in the last year, from September 2019 to September 2018, there was a mild increase in volume of the disease. Any other question? No? Okay. Eldad, do you have any question about the imaging that you see here?
No, I mean we see intensity in lesions, intense lesion. Diagnostically, it does look that it's growing. And from the IR perspective, there's not much that I can offer. So the anatomical real estate there is too risky for things like cryo or toxicity embolization.
Okay. And Alessandro, you would probably not offer any surgical approach in this case? Okay. No, okay. Okay.
One question probably about that.
Yes.
Even if it's not a measure of cryo, do we have a sense of the vital structures nearby that are currently threatened by the tumor? I don't know that. I don't know about threatened by the tumor. I really want to know what the symptoms were if it was just pain, but I don't think there's a threat in terms of vascular threat, and I'm not sure if it's close to the temporomandibular joint.
Do you want me to go back into imaging? It was clinically, it was quite close to the. It is quite close, actually. So it's probably not going to be possible. And actually, we did that assessment, and it was not really possible. So the question, obviously, we already gone through some of those questions, is whether or not local treatment versus systemic treatment, and if we have excluded the local treatment, what's systemic treatment? And maybe I'm turning to you, Ravin.
So I think part of the reason I asked the questions that I were was, so, here in the United States in 2022, 23, that's where we are. I think we're getting there. So one assessment that we're going to be doing is this patient is a candidate for a clinical trial. So the reason that I asked about the progression in the prior 12 months is that previously the IRCCS and now the IALA trial required 20% growth in the prior 12 months. And Dr. Dileo confirmed that in fact patients had that level of progression, which puts that kind of a study on the radar. Now it passes through cancer, we have to figure out if that excludes them or not, when we start to screen a patient to see their cancer for study. One thing that hasn't been talked a lot about, though, is are you comfortable with the randomization, right? So in other words, is this a patient that you would feel comfortable allowing the tumor to grow by a further 20%? Because it's a flip of a coin. They're either going to get placebo, or they're going to get the study drug. And the only way that they have access to the study drug if they get placebo is by growing by 20%. And so we did meet patients over the course of conducting the study whose tumor had grown by the amount that needed to grow, but we were uncomfortable putting them on a study because we didn't feel it was in their best interest to go to a placebo. So that's why I asked about that. So that could be a conversation. We would care who reveals it to the radiologist. Putting that to the side for a moment, I think that our standard of care in recent years has been a tyrosine kinase inhibitor, most commonly sorafenib, although pazopanib is not a medication that we could use for this patient. Legacy or older therapies like methotrexate and blaspheme or doxorubicin-based treatments can also be considered. In general, for a patient like this, most often are going.
Can I ask you about? I always have the same approach in terms of not using the placebo, particularly in an area where there is a possibility of, obstructing the airways of an. In this particular case, it doesn't necessarily seem that even a small progression was going to affect the airways. So maybe going into the DeFi at that point was probably going to be okay.
So I think I would not make that assessment based on the slices that you showed.
Sure.
Be careful for the discussion with the radiologist. Looking through the three dimensions, are we concerned about this? Do we think that's safe? And so I wouldn't necessarily have an issue with that decision. I would just want to make sure that we brought that.
Of course. So I'm going to show the next slide. Oh, sorry, go ahead.
Two comments. Number one may ask why you not proceed the opposite. I mean, every saying that surgery can be avoided, but going why you should have. The reason why we don't do that is because surgery and neck is often not able to be present because the risk of subsequent recurrence is very high, and then it becomes complicated to handle the recurrence in this surgery. So, like a complicated side effect surgery, extended class, and then last with neck and muscle, so on, last that area. So it becomes rather complicated to do that. And so this is the first comment. So we don't do surgery because of this, because of this tissue loss we call the surgery, the function of calculate and the risk. The high risk of subsequent recurrence and what we have to do subsequent recurrence in that way. Second thing I want to say is that the other local therapy, right, once you excluded in interventional radiology, so therapy or improvisation of pieces, therapy, therapy in the patient, because again, so he has a rehab of cancer. So he has all these life experiences ahead of him. So when the therapy is a tool that you can use sometimes, it's not associated with high risk of major side effects in terms of major systematic cancer, but it does have some side effects in it. So that's not very good. Patient was already had other cancer, chance to have so that's the reason why you don't use therapy. It does you do use for a lab, which is just there as it goes into cancer. So that's why you use medication and not. The other last comment I made, when you are in active surveillance, the doctor has always to check the baseline scan beyond the patient.
Fact.
Because you might miss otherwise certain loss. You may go 1 millimeter at a time, but then after 10 scans, and once a minute.
Exactly.
Which may be substantial things that the negative side. So it's always important to use the baseline assessment as your reference to look at rather than the baseline. This is something the doctors sometimes miss. So if a radiologist is not an expert, it's not uncommon that the comparison is made with the baseline. They don't change the baseline. You heard it's a 20% increase in size, which qualifies for progression. So if it change every time, you just comparing the baseline by the end of the year. You must not quite.
So, and if we go to the next one, this is the local multidisciplinary team review outcome, meaning what? So there was actually a RECIST progression confirmed over the year. The patient was potentially eligible for the DeFi trial. The trial was discussed with the patient, and the patient, when offered the option, did prefer to go into the chemotherapy option rather than the trial, and commenced methotrexate and vinorelbine at that point. And this is what happened afterwards. And those are the imaging from the baseline MRI in September 2019 and then January 2020. And I will let Eldad this kind of give some. I know that is not the best, but Yeah, well, I don't have a pointer, unfortunately, here, but we need to do with the finger.
Okay, all right. So we have this is basically the spinal cord over here, and the mouth over there. So the lips are over here, the back of the head over here. So this would be this is the right side of the patient, left side of the patient. This is actually where it is. So you can see this is the asymmetry.
And that's
Oh,
so
okay, sorry.
before and after. Is actually smaller.
Actually, you know what? I think this might be better. Can we do this?
Oh, do you have the
Can we see this?
Okay, yeah. So they are. You have the pointer. We have the pointer.
Okay, all right. So there we go.
That's the area.
This is the area where January and
September.
September.
Yeah.
I mean, okay. This is a T2-weighted image, and what we see there's some change. I'm not going to measure it, but it looks a little better than it's worth. See that black part over here compared to what we have here? So a little bit of loss. It looks a little bit smaller and a little bit darker. That's the formal.
And actually, this one is another slide of the same.
So
Yeah.
the other thing is important to understand that the drugs are not all the same. And for example, gamma is in the rotospan, the things are faster activity. So you see it's faster. Some other drugs are different.
It takes a little bit longer. And in fact, this is the next one.
So this is a really nice response.
This is a very nice response. In fact, that is January, and that's May 2023. September 2019. No, 2023.
So I usually counsel patients on this treatment that it's going to take at least 6 months before we can really tell if it's working, if we may have to count this treatment for 1 or 2 years. So it's slower. It does work, but it is slower. I'll be prepared for that.
And actually, this is after 2 years having stopping the drug.
So the usually when we use drug, just not as NGS treatment of the cancer is used, but then you stop it.
And he's doing okay. Okay, so let's go to the next one. This is a very intriguing one. So 32-year-old woman diagnosed in November 2019 with a left, just making note of the left and right, left abdominal wall desmoid that spontaneously regressed. And then in April 2023, there was another on the right side. Now in 2019, she had a biopsy that was confirmed with also mutational analysis and was a S45P substitution and was on active surveillance. Okay. And past medical history, nothing particular relevant. She had a colonoscopy that was negative, and this was done for other reasons. And a family history, nothing particular relevant again. Imaging not particularly nice because they were done outside our institution. And the baseline, maybe you have a pointer there, you can show everyone.
Oh boy. So, radiology. So again, this is it's not used to looking. We don't look at people like this normally, but if you're looking from the feet to the head, this is like a slicing of gray. And so the person is lying on their back. That's the back. That's where the umbilicus is. And then this is the wall of the chest. So this over here is that desmoid chest wall. Yeah, abdominal wall. Oh yeah, abdominal wall. And then what we have over here is a magnified image.
Yeah,
So it's kind of zoomed in image, and this is
that's a mark.
A marker of where the technician will place this marker, because the patient will say, this is where it is or was. Okay. And so, again, we can't really forward read this is a magnified. That's where we'd expect to find it. And there are other differences between these two images.
But actually nothing was there.
But it's gone. The body language, it's no longer
And then there are other similar pictures that show that nothing is there. And also, then she was lost at follow-up. For some reason, she didn't come to see us. She had a pregnancy in the interim, and that represented in February this year, but with new symptoms. But on the other side, instead of on the left side, this time was on the right side. Clearly, we were concerned that there was something different, and at that point, biopsy that area, and to exclude that there was something more sinister, and the biopsy was seen. There was a discussion at the local MDT, as you can imagine. I suppose that everyone would have done the same. And do you confirm that you would have biopsy? So we did the biopsy, and here the imaging of the lesion that was exactly on the other side.
Okay.
It's not something that has migrated from one side to the other. It's exactly on the other side.
Yeah. So now we have back over here, the belly button over here again, and the abdominal wall, and this is the part right here. You can see the asymmetry. That's it. Again, over here, for anyone who didn't. So interestingly, something else, another rare tumor, same person.
And we did the biopsy. We confirmed that there was something there, and I'm sorry, something that I'm gonna. But most importantly, not only we confirmed that was the same diagnosis, it was a desmoid, but a completely different mutation, which was quite unusual. We see in other sarcoma that there are other, what we call secondary mutation, but I've not seen it in desmoid. But anyway, it doesn't. It happens. Now we have imaging that shows that unfortunately has grown in the meantime between February and June. So my question to the panel is, what would you recommend in this case?
I just want to reassure you that's a very exceptional thing. It doesn't really happen all the time.
Yeah.
And what happened here is that she developed a second desmoid. The reason why they did the mutation and it was tumor, so they're two completely separate entities, meaning that she basically had an event which is not correlated to the previous one, unless you consider that this double occurs two different desmoids, and is related to some predisposition or something that she actually has, but normally it doesn't happen.
Mm-hmm.
Yeah. So what do they do here? I mean, I would try not to do surgery because she already had a sign and see that pregnancy kind of stimulated very long. So surgery is also another trauma that can also occur the same thing. And so I consider local therapy, because this is a perfect candidate for local therapy, cryo or embolization, or
Question for you, Alex. I think for a gentleman tumor for dislocation, for the setting aside the complexities, pregnancy, and all that.
Exactly.
What does that surgery look like?
it's an easy surgery. It's an easy surgery, and though it will always require to put a mesh to compensate for the extension of the abdominal wall. Having a mesh in the abdominal wall may become an issue in mortal pregnancy, because then the mesh is not elastic like the muscle of the abdominal wall. So when you have this tension of the abdominal wall, because the leak is blocked, there is mucus, then that mesh breaks down. So you need to put it back. The pregnancy has some issue during the pregnancy because of this tension of the wall of the muscle there. So it's not impossible, but it's certainly something to consider when it comes to the cellular surgery and this challenging age and whatnot.
And Eldad,
From
would
the
you?
role perspective, yeah, this is a small, accessible tumor for cryoablation.
Even if now that is grown.
Yeah, so even in that sense, it's still relatively small, and I would be comfortable with either. So this distribution, the vessels that feed it, circumflex iliac and inferior gastric, so we know where to go to find that tumor, and I think to what it's one or the other.
Okay, so obviously I agree with Alessandro that is absolutely a unique presentation. It's not definitely not something that happens all the time. But I had chosen this mostly because of the presentation, the location of the tumor. Ravin, if in terms of systemic treatment, in case, what would you suggest if one or the other would not be possible?
I mean, I think we're choosing from the same menu things that we did before. So we typically want to make a patient like this. If they're minimally symptomatic, I would also mention that you don't have to jump immediately into treatment. This is growing. If you can continue to surveil a tumor that has grown some. Because sometimes it is federal. So if they're minimally symptomatic and there's what's that?
One point, so the abdominal is a typical location where you can wait longer anything other than having Milan, which you can't be visible. Of course, we should not like it, at least in the medical, but it doesn't happen anyway. So you can.
So I think that for a patient that's not bothered by it, we'll still keep that on the table as an option. But again, for the personal discussion, setting that aside and talking about treatment. If you have progression in the prior 12 months, you can consider the studies that we can discuss. That are based on the past now, I don't know what it is. Ravin is commonly used at patients with methotrexate and blasting, which is what the last patient showed. Also reasonable options. So typically when I make these decisions, we talk to a patient and get a sense of what they prefer. There's no emergency to shrink this tumor. So methotrexate and blasting works slowly. It's also really well tolerated for one patient. It doesn't take the idea is what's less comfortable, unless less convenient than an oral treatment. But patients often feel quite well. So a patient could choose a slower therapy for the interferes less with their quality of life. Most patients prefer the oral therapy, to be honest. That's what most patients say that too. That's what's Ravin.
When do you consider doxorubicin-based doxorubicin?
Yeah, it's a great question. So I think doxorubicin is cytotoxic chemotherapy. And so what that means is that it's sort of what we think about when we think about a chemotherapy drug. So conventional doxorubicin is the really aggressive stuff. You lose your hair, you're going to infection. Doxil, which Dr. Alessandro just asked about, is a special formulation. You don't lose your hair. It's actually very well tolerated. side effect wise, people can do quite well with mouth sores and with skin irritation. But there is this risk of secondary malignancy down the road. So the young patient may not the first thing that I would do. I prefer to methotrexate lastly. Cardiotoxicity risk is very low with toxin, not something I'm so worried about. But I think that it's typically not my first play in a younger patient for those reasons. There's no comparative data, but it probably works about as well as methotrexate lastly. I think it's sort of our sense of doing it systemically.
We are using more and more oral vinorelbine as a, instead of methotrexate and vinorelbine, and it's very well tolerated and is oral, so it's absolutely,
The study, it is true that the infra-abdominal wall, there's one, but are not arising in the context of HIV. And the behavior, not the cause, is really very important. So this is a tumor that if it's resected, never comes back. So if it is treated locally, it can usually have wonderful results. So it's not the location you see unless the recurrence, unless the thing is really growing fast, or the patient has increased. That's not the location to consider first medical therapy. In general, the local therapy will be sufficient if you are willing to take long enough for the study that you really doesn't to stop. Yes, these are the monitoring ones.
The simple reality is most patients will choose a one-time procedure over months and months of medical therapy. So I totally agree that if the local
generally speaking,
that is what I would recommend. So all of my colleagues are sort of with that, and that is on the table.
I'll just explain why local therapy is so relevant here. It has to do with the collateral damage potential. So when you're looking at a tumor that's right up here in the neck, there are a lot of nerves and arteries and joints there, and a lot of potential for damage. And we use our face much more than we use the side of our abdominal wall. And as much as if there's a decrease in function or nerve injury, if there were over here, it's acceptable, and over here, much less acceptable. So just to give you an idea of what the considerations are.
Yeah. So we are going to finish now, and just to kind of say that the patient is choosing surgery and is waiting to discuss with the surgeon. But obviously, we have discussed all the other question, the other option as we did today now. And that's pretty much it. Thank you very much, everyone. And I hope you have enjoyed the discussion as well.
Speak very loudly.
Okay.
With the medication therapy, would that mean that response to the medication?
How do you monitor?
Would there be like
Two different mutations.
You have two tumors, you have different response to therapy.
I don't necessarily know that we know about it, to be honest with you. I think that we would probably do the same thing.
It wouldn't change my treatment.
No, I don't think so.
But I think that I absolutely think there's a multifocal medical patients that have differential responses to their tumors. That can happen. I doubt that most of them probably the same patients did. I don't check that for all patients. But there can be differential responses that can happen.
This was a very, very unusual case because, of course, something disappeared and something appeared on the other side, and of course we needed to do that, and the mutation was different, but otherwise we probably were not gonna biopsy every single one.
Great, thank you.